Okay, good morning, everyone, and welcome to this presentation. This presentation is part of the Whole Health Innovation in a Time of Uncertainty project. My name is Derek Noland. I'm a community liaison here at the Behavioral Health and Wellness Program at the University of Colorado's Anschutz Medical Campus, and I'm the grant manager for this project. And as part of this project, we have 3 webinars this spring. And the first one today is called Understanding the Colorado Behavioral Health System. And I'll introduce the webinar today and some of the initiatives for the project that are forthcoming in the next few months. And then we'll begin with the presentation. So today, our objectives are to outline the structure and key agencies and administering the Colorado Behavioral Health Services. We'll discuss different levels of behavioral health care, and we'll provide context for a behavioral health care coordination model that will be introduced soon. So as I've mentioned, the Whole Health Innovation Project offers training and technical assistance around tobacco dependence treatment to behavioral health agencies. So the purpose of the project really is to incentivize organizations around the state to implement self-directed goals to expand their tobacco treatment services and/or policies. And so in exchange for participation in the project and for pledging to do that, the Behavioral Health and Wellness Program is then able to offer free seats at some of our tobacco trainings and technical assistance throughout the course of the year. And we also offer this series of webinars as well. A little later this spring, we'll be unveiling our behavioral health care coordination model, which will be designed to help orient people to the behavioral health system in Colorado with the ultimate intent of being able to understand where we can route people for tobacco dependence treatment services. We'll expand upon this initiative next year when we take a step further, and we will create a toolkit that will help instruct agencies in how to effectively utilize that model so that we can really take advantage of that, that creation. So as I've noted, we have a spring webinar series this year. So we have 2 upcoming. Beyond this first webinar, we'll have one on Tuesday, May 3rd at 10 a.m., which will be titled A Model for Tobacco Dependence Treatment Within the Colorado Behavioral Health System. So we'll look at how to route patients within that system, start to focus more on tobacco in that second webinar. And the third one on June 7th at 10 o'clock, Engaging the Colorado Behavioral Health System, Routing Individuals to Tobacco Dependence Treatment. We'll do more actual case studies and examples, and we'll have some field experts on the line there to try to help guide that conversation. Okay, but today I'm very happy to introduce Dr. Charles Smith. Dr. Smith is the Regional Administrator for the Substance Abuse and Mental Health Services Administration, or SAMHSA, in the U.S. Department of Health and Human Services Region 8. Dr. Smith is the former Director of the Colorado Division of Behavioral Health and Deputy Commissioner of Mental Health and Substance Abuse for the state of Colorado. He is a licensed psychologist with over 30 years of experience in fields of forensic psychology, addiction psychology, crisis intervention, integrated care, and behavioral health policy administration. Dr. Smith holds a PhD in counseling psychology from the University of Denver, a MA in rehabilitation counseling from New York University, and a BS in psychology from Allegheny College. And with that, I'll turn it over to Dr. Smith, and he has said that if anyone has pressing questions during the presentation, that he's happy to field those at that time if you think that that is the best way to have your question addressed. And we'll also have time for some Q&A at the end of the presentation today.
Thank you, Derek, and good morning, everybody. So I'm going to do my best here to kind of grab a slide, and so that way I can share them. Give me a second here. All right, Derek, am I coming through?
Yep, that looks good.
All right. So Derek, again, thank you for the introduction, and really appreciate the opportunity to kind of join all of you for hopefully a an engaging conversation, at least some discussion with regard to the behavioral health care system, not only nationally, but also here in Colorado. And as Derek indicated, feel free to kind of put questions to me in the chat, or if you want to raise your hand, we're going to do our best to kind of track those. And so Derek, I probably will be leaning a little bit heavily on you for that. So kind of let's get going. So I want to kind of start off and just kind of provide at least a little bit of a frame with regard to kind of the prevalence rates with regard to mental health and substance abuse across the country. One of the things that SAMHSA does, the Substance Abuse and Mental Health Services Administration, is that we administer the National Survey on Drug Use and Health, which is an annual survey each year that looks at prevalence and service utilization across the country. So the data that's being presented here was published this past fall. It reflects 2020 data, since our reports tend to be about a year in arrears. But however, this is the first time that we captured national data after the start of the pandemic. But we see around 73, just over 73 million adults had either a substance use disorder or any mental illness, and the AMI stands for any mental illness. You'll see around 52, almost 53 million adults reported having any mental illness, and around just shy of 38 million had a substance use disorder. And I really kind of want to draw your attention to the fact that there's a fairly significant concordance with regard to around 17 million individuals identifying both a mental health and a substance use disorder. The next slide, which, hold on just a second.
Sorry to interrupt, Dr. Smith. You may prefer to have it in slideshow mode so that this each slide takes the entire screen. Sorry, I didn't recognize that earlier.
No, it's fine. I thought I had it, so my apologies. Maybe I don't. How about now?
I think if you click the slideshow button and then I think play from current slide, I think, or something along those lines.
Yeah, I thought I had it. Say, let me do this. Hold on just a second. How about now?
Still the same.
It is, isn't it? Well, it's not being friendly for me.
Well, we can see everything.
Let's do this. How about that? Is that a little bit better?
Yeah, it's one at a time now.
All right. So my apologies, everybody. Clearly, it's a tech failure on my end. So I've used this slide for many years as a way of kind of really kind of talking about the state of our behavioral health care system. And this is not a Mega Millions lottery number that I recommend you playing, but feel free if you are so driven. But 95, 75, 55, 11, and 94. 95 actually represents the percent of individuals with a substance use disorder who do not believe that they have a problem with substances. 75 represents the percent of individuals with a serious mental illness who do not believe that they are understood, recognized, or seen by friends and family members as having a mental illness. 55 represents the percent of individuals, particularly adults, with a serious mental illness who have access to mental health services in their communities. 11 represents the percent of individuals with a substance use disorder who have access to substance use disorder treatment. And 94 represents the percent of individuals with asthma who have access to physical health care for their asthma. So I think that 94 comparatively to 11 and 55 really kind of speak how our system has disproportionately provide emphasis with regard to easier access, equitable access to care for individuals with a chronic mental health and or substance use issue. Those are significant. There have been a number of different models over the years, and that still are in very much existence and play to actually help describe and or drive or frame the behavioral healthcare system. And when I speak about behavioral health, I'm referring to the systems for both mental health and substance use disorders. So the Institute of Medicine, I believe it was about 12 years ago, published kind of the FAN model, which really kind of emphasized this continuum across health promotion, prevention, clinical treatment, and recovery and rehabilitation. And this model has actually been used in the federal government for many years to help kind of drive and frame the various roles and funding opportunities that the federal government makes available in trying to craft a system lens for the country. However, its application it's difficult to translate at the state and local level. In the top right is the Association for the Society of Addiction Medicine that actually built out the continuum of care for substance use disorders, which really kind of articulate for substance use disorder treatment various levels of care, which cross-cut early intervention through intensive outpatient treatment, through partial hospitalization, inpatient services, and clearly the role that medically managed services are actually delivered for individuals with alcohol and other drug use disorders. And then finally, on the bottom is what was developed several years ago, close to 20, which is the sequential intercept model, which was a way in which our country at both the national as well as local levels has been able to frame this intersection between individuals with serious mental illness and our criminal and juvenile justice system. And they talk about it as intercepts. And so if we think about community services as intercept 0 through law enforcement engagement, through jail and or prison detention, the court system, reentry from jail or prison, and obviously community corrections. And kind of, again, trying to explain how our systems operate and intersect as a way of kind of modeling. Now, SAMHSA does not have this national model, nor does the U.S. Department of Health and Human Services have a national model for behavioral health crisis services. However, we are operating in a number of kind of submodels that are helping kind of frame portions of the system. This is a diagram that explains our comprehensive behavioral health crisis response system, which is being currently used as a way of kind of really understanding individuals in both a mental health and or substance use crisis. And the fact that we have a crisis line system, we offer mobile crisis stabilization facilities, and post-crisis wraparound services, which oftentimes include referral to community-based and or inpatient services. Sadly, though, as the model kind of depicts, is that our mental health and substance use system has been enormously reliant and almost the de facto crisis system for individuals with mental health and substance use has been our law enforcement system, which we recognize is not consistent with how we think about individuals with a physical health crisis. So this is another way of representing our behavioral health system, obviously from the unique lens of a crisis response system. This slide is another example, albeit it is very challenging and somewhat confusing to look at. But SAMHSA, along with support from Congress, has been really trying to standardize its vision of what a community mental health system looks like. When we think about community mental health services, which now are much more inclusive of substance use disorder services at the community level, there's not a standard model. So what we see in Colorado is not uniform across other states in just this region, as well as looking at states in such as California, Texas, and New York. This model looks very different. So the federal government, with significant investments, is looking to establish what are known as certified community behavioral health centers. And this is the model that's being used to really kind of identify those standards of comprehensive mental health and substance use treatment services, which are patient-centered and trauma-informed, recovery-oriented, clearly and intentionally integrated with physical health care, with a 24-hour crisis component, and clearly a standard of care which brings evidence-based care to individuals with mental health and substance use. And so you will see, and actually Colorado has 4 of the CCBHC funding models currently under development, and there's great interest in the state of Colorado to really formalize this, as we've seen in several other states in the country. Obviously, making the shift to this model takes a fair amount of resources, including funding. But again, it's another example of how there are sub-models helping to describe what our behavioral healthcare system is from a national perspective. So one of the things that I've talked about for quite some time is the fact that there are kind of 5 main features to a healthcare system. And these apply to whether it's a physical healthcare system or a behavioral healthcare system. And they really emphasize, one, the role of population-based public health that is focused on the health and welfare of an entire population, as well as communities, families, and individuals, as well as identifying strategies where prevention of poor health or risky health behaviors is paramount. And that may be some of the issues focused on tobacco prevention activity, harm reduction activities for opioid use, a way of educating the public with regard to what is a mental health condition, as well as fortifying the public with regard to how best to respond to individuals in crisis, all of which surround this public health community prevention element of a behavioral health care system. The second is obviously an urgent crisis care system, which I had mentioned earlier, that SAMHSA is looking now to intentionally drive some standardization of what our crisis care system is. But we need to be thinking about a crisis urgent care system in the same way we think about it as a physical healthcare system that's driven by an emergency response from a medical standpoint rather than a law enforcement response. There's a primary ambulatory care system for both physical health as well as behavioral health, but we don't talk about it in the same way in behavioral health care. There are community mental health centers, substance abuse treatment programs, oftentimes offer ambulatory primary substance use and mental health care. But again, we do not talk about it in the same way as a community health center or a federally qualified health center. But their intention is to actually provide immediate, initial, early intervention, screening, identification, and in some cases, treatment for mild to moderate symptoms for mental health and substance use conditions. And we know within our federally funded community health centers, the FQHCs, HRSA, one of our sister agencies, is substantially investing in those centers to actually provide that primary ambulatory care for mild and moderate mental health and substance use services. And that can be a nice adjunctive to the community mental health service model that's currently in place and funded not only by SAMHSA, but also CMS. The fourth area is really thinking about specialty care. And we need intensive outpatient services that are ambulatory, that keep people in the community. And we also need that specialty care function around inpatient or residential care for serious mental health, as well as substance use issues that have moderate and or serious or complex symptomatology that intensive courses of treatment can only be managed in a specialty care environment. And then the fifth area is really elevating the importance of rehabilitation and recovery support services, appreciating that there's been a long history of psychiatric rehab models and the recovery support model. And recovery is really a terminology that emanates out of our addiction field, but really understanding that there are elements of helping individuals with chronic healthcare conditions to attain and maintain their stability, not only for their symptoms, but their engagement within society. Understanding that their overall health is important, their connection to family, friends, community, faith-based organizations are important. Their involvement in having purpose in life, whether it's through education and employment, are significant elements of that recovery support model. And all 5 areas that are described here really describe our behavioral healthcare system. And a couple of the pictures on the right-hand side are SAMHSA's recent publications over the last couple of years to begin shaping that, even though we do not have, there is not a national model for behavioral health care, but that is coming into focus. And I wanted to kind of really highlight those 5 areas that we think about, at least here in the regional office. Now, there are several core features to what the behavioral health care system is. One, we know that emotional health and well-being are vital to our overall health. We have to make sure that we're elevating and talking about mental illness and substance use disorders as chronic illnesses. As seen by the Surgeon General's report in 2016, that he, for the first time, put a stake in the ground to say that mental health and substance use disorders are chronic illnesses, and we need to actually structure our entire healthcare system to treat them as chronic illnesses. We know that equitable access is critical as a public health strategy. The science regarding the effectiveness of mental health and substance use treatment is tremendously strong. Actually, a report from NYU about 5 years ago evaluated relapse rates for asthma, diabetes, and substance use disorder treatment, and saw that relapse rates were lowest amongst individuals in substance use treatment as compared to those in asthma and diabetic care. We know that integrated behavioral health needs to be integrated and coordinated across the entire spectrum. We know that behavioral health treatments have to be tailored to the individual, really understanding the environmental and social impacts and how they are impacting their clinical picture and profile. And then finally, really the engine that makes any system work is our workforce. We need to make sure that our workforce is well-trained, competent, and staying current on evidence-based practices, which are essential to our individuals and families and communities that were receiving care from our systems. Now, making a little bit of a shift, okay, what does the federal government do? Well, we play a big role with regard to assuring the health and well-being of all Americans. And the U.S. Department of Health and Human Services serves in that role. There are a number of different agencies that are listed here, and you will see SAMHSA and CMS and the CDC, which are probably common language for many of you who are on today's webinar. But you'll see a symbol in the middle right-hand side, which is actually a symbol for Indian Health Services, the National Institute of Health, the Administration for Health Research and Quality, AHRQ, the Administration for Community Living and Children and Family are also part of the HHS family, all of which who have a role with regard to mental health and substance use. While SAMHSA plays a lead federal role for mental health and substance abuse across the service continuum of prevention, treatment, and recovery, we cannot do it alone. And we're relatively small fish, particularly in comparison to CMS, which I'll talk about here in a moment. So SAMHSA, a little bit about SAMHSA. We're just turning 30 this year. Our mission is to reduce the impact of substance abuse and mental illness on America's community. Interesting, there's a piece of legislation right now to remove the word abuse from SAMHSA's title and actually move it to substance use and mental illness in America's communities. Our tagline is in the middle. We really recognize behavioral health is essential to health. Prevention works, intervention is critical, treatment is effective, and people recover. I'll talk about our 5 priorities here in a moment, as well as cross-cutting principles. Our budget last year was around just shy of $6 billion. This year, it's just shy of $10 billion. But in addition to that $10 billion, there's been a significant, unprecedented, quite honestly, investment by Congress into mental health and substance use as a result of COVID and the American Rescue Plan. And I'll talk in a moment here a little bit about where those dollars typically go and how you might see them impacting our communities, at least here in Colorado. SAMHSA is organized in kind of 5 main areas. There are 4 discrete centers within SAMHSA that really are kind of the engine for SAMHSA, where the money from Congress actually then gets executed in those 4 specific areas of prevention, treatment, mental health services, and statistics and quality. And then our Office of the Assistant Secretary. So SAMHSA's Assistant Secretary is Dr. Miriam Delphin-Rittman. She was appointed by President Biden this past May, and she serves in the capacity that oversees all of SAMHSA, and then myself and the other 9 regional administrators serve as a regional representative for the Assistant Secretary. Our operations kind of really very much focus on leadership and voice, funding, data surveillance. We do an awful lot with regard to training and practice improvement, as well as regulation and standard setting, which I'll talk about here in a little bit. So I mentioned these 5 pillars. Our administration, or SAMHSA, is very much focused on these 5 areas, and quite understandably, it's not surprising that we're maintaining our focus on the overdose, particularly opioid overdose epidemic, which has now reached over 100,000 individuals dying by a drug overdose this past year. We're focusing on enhancing access to suicide prevention and crisis care. For the first time in SAMHSA's 30-year history, promoting children and youth behavioral health is a principal area of focus. And actually there's the intent with support from the White House to actually craft a national child youth behavioral health agenda. We're staying very keenly focused on the importance of integrating primary and behavioral health care. Much as I had mentioned the CCBHC model earlier, that's very much enveloped within this pillar 4. And then finally, really understanding the importance of data to tell a story beyond just prevalence and service utilization, but really understanding what programs are effective and how best are we reaching individuals and assuring that the quality of care is maintaining the highest standards. There are 4 cross-cutting principles that we're definitely focused on as an agency: diversity, inclusion, and equity, workforce, financing, and recovery. And appreciating that financing, as I mentioned earlier, we're a small fish. As much as $10 billion seems like an awful lot of money, and it feels like an awful lot of money from my position. If we compare that to the $1.9 trillion that CMS manages, of which a large percentage actually supports mental health and substance abuse, we know that they are a significant player when it comes to financing. And we need to be thinking and working closely with CMS to think uniquely about how best we can actually build a system that's supportive of individuals and take advantage of blending and braiding federal dollars in the most effective way at the local level. So there are 10 regions for SAMHSA across the country. I'm smack there in the middle, which is Region 8. So we cover the states of Colorado, Utah, Wyoming, Montana, North and South Dakota. And within that territory, there are 33 recognized tribal nations that we work with very closely. There are 9 other regions which cover the entire country, and our offices, while small, we are mighty. They're typically 2-person offices, and actually I believe that our Assistant Secretary Tracy Pohl, who is actually on today's call, as well as we actually offer a graduate fellowship in public behavioral health policy. So if any of your students and or colleagues have interest in diving in and working with SAMHSA here in the regional office, feel free to have them contact me. But we serve in this capacity and have an opportunity to really work locally and closely with not only all of you, but also with the Behavioral Health Wellness Program at the University of Colorado. So thought it might be valuable to kind of get a sense of where funding and resources out of SAMHSA actually really kind of come together and make an impact. So the majority of SAMHSA's money is actually harnessed in the 2 first items. So there are block grants that go to every state, one of which is focused on substance abuse prevention and treatment, and the other is focused on community mental health services. These block grants are fairly flexible. However, they have slightly different definitions in federal laws as to how they can be used. But basically, they serve as kind of the foundation, the buttress, if you will, for Colorado's behavioral health care system. In addition, every state receives funding, PATH funding, which actually supports individuals with serious mental illness who are homeless or at risk of homelessness. Every state receives money to actually provide protection and advocacy services for individuals with serious and persistent mental illness, primarily providing that advocacy for individuals in our state psychiatric hospital system, of which there are 2 state psychiatric hospitals here in Colorado. And then actually started during the Obama administration, Congress laid out what was known as the state opioid response dollars, as well as tribal opioid response dollars, which allowed an additional pot of money to go to every state to address the opioid epidemic, as well as now flexible funding in that to address stimulant use, such as methamphetamine and cocaine, which we recognize, at least in this region, are substantial drivers for substance use disorder treatment. Now, where do these monies actually go in the state? Well, in accordance with federal law, every state actually has to have a state substance abuse authority and a state mental health authority. And those authorities serve as the point of contact for all 5 of those block grant or formula funding opportunities that I mentioned before. In most states, I think right now it's around 44 or 46 of the states in the country, those two authorities are merged into one office. So in Colorado, the Office of Behavioral Health serves as the state substance abuse authority and the state mental health authority. And so they are the recipients of all 5 of those funding streams that I mentioned before. When I was the state director, I served as both the SSA and SMHA here in Colorado. Now, what is also kind of important is that in federal law, every state has to have what is known as a mental health planning and advisory council, which actually has to advise the state, specifically the state mental health authority, on how they're to use the dollars that they receive from the federal government. And it's not only using these $5 that I mentioned above, but it's also how Medicaid dollars are being used, how are 4E dollars being used for child welfare, and some of the other federal funding sources that this advisory council has to provide guidance to the state and recommendations. Now in Colorado, like actually several other states, they have actually expanded this planning advisory council to include substance use. So in Colorado, it's known as the Behavioral Health Planning and Advisory Council. And what other feature that's important is that this council must be at least 51% family members, consumers, as well as advocacy organizations, representing and advising the state on how to use the funding. In addition to formula grants, SAMHSA distributes a number of different competitive grants in a variety of different topics. They actually emanate out of 3 of our centers. They focus on substance use prevention, substance use treatment, and community mental health services. And this gives you at least a sense of what those funding opportunities are. Some of you may be familiar with them. I won't go through them. And again, these are just examples. I'm not even sure how many different types of grants, but I would argue probably well over 100 different types of grants that are made on an annual basis that are competitive. SAMHSA also does a fair bit with regard to funding technical assistance and training and consultation around the country, again, on a variety of different topics, whether it's housing and homeless resource center, whether it's focused on eating disorders, whether it's focused on the intersection between criminal justice and behavioral health, a focus on older adults. But I want to draw your attention to the top left, which speaks about our technology transfer centers. There are 3 centers of excellence, otherwise known as technology transfer centers, in every region. So there's a center of excellence for substance abuse prevention, a center of excellence for substance abuse treatment, and a center of excellence for mental health in Region 8. At the University of Utah is the Prevention Center of Excellence, and at the University of North Dakota, they operate the Mental Health and Substance Use Center of Excellence. These provide free training and technical assistance, continuing education programs, consultation to programs like the University of Colorado, and you do not have to be a grantee of SAMHSA. So these are free. You're welcome to access them through our website, or if you have any questions, you're welcome to contact me directly. Additionally, SAMHSA runs a number of the national lifelines, including the National Suicide Prevention Lifeline. And if you're not aware, this lifeline, 1-800-273-TALK, is moving to a 3-digit number in July. So if you hear about 988, that's what that refers to. We run a veterans crisis line, a helpline, a disaster distress line, a drug-free workplace line, as well as we operate a national behavioral health treatment locator, which can allow you, consumers and families, direct access to behavioral health treatment providers within your state as well as local community just by putting in your zip code, as well as their treatment locators around buprenorphine, early serious mental illness treatment locator, as well as an opioid treatment program locator. So let's talk a little bit about the roles of government in behavioral health. And there are some differences, albeit the differences are slim between federal, state, and local. Clearly, the federal piece plays a national leadership. We look at national policies, rules, and standards. We offer funding that actually emanates out of Congress. We do a fair bit of program implementation and quality assurance, research and surveillance, albeit SAMHSA is not a research entity. We rely heavily on the National Institute of Health and our colleagues at NIMH, NIDA, and NIAAA, as well as the CDC. SAMHSA does not provide direct services. However, 3 other agencies within the federal government do. And those are Indian Health Services, the Veterans Administration, and the Bureau of Prisons, are 3 specific federal departments that operate direct healthcare services, including behavioral health. And then the federal government does a fair bit of consultation and guidance, really from federal to state, as well as federal to local. At the state and local government level, they're doing the same, but they're coming from a state or local government lens. Same thing with leadership and policies and standards and funding and quality assurance. Some state and local research and program evaluation, and clearly much more around direct services and consultation. But when we start looking at funding, the funding gets a little tricky. At least for HHS, as well as for some other federal agencies, our funding typically goes directly to states and territories, much like I described with our formula grants. And the same is true with regard to going, funding from CMS is going to go to the state Medicaid authority. Here in Colorado, that's HCBF. The state Mental Health and Substance Use Authority is the Office of Behavioral Health. The state health authority is CDPHE, and they get funding directly from the CDC and in some cases HRSA. And then there are other state departments that receive federal dollars that have linkages to behavioral health. And at the local level, they may be getting federal dollars through discretionary grants, at least from SAMHSA, but oftentimes they're getting money from the state or territory. And that could be county health departments, private and nonprofit agencies, community-based organizations, colleges and universities. And again, this is not an all-inclusive list, but it just gives you some sense of the diagram of where federal money and state money may actually be going and how it touches both state as well as local entities. This gives you a snapshot of roughly the $180 million from SAMHSA is coming into the state of Colorado. I recognize it's a little bit busy, but kind of following the same theme and structure that I've been kind of presenting, it gives you a sense of where the formula funding is actually coming from SAMHSA and how much and where it's going within the state, breaking it down by each of those 5 categories. And then on the right-hand side, the various discretionary grants that have been awarded to local communities, to private not-for-profit agencies, to universities within the state of Colorado. And compared to what I experienced as a state director 10 years ago, this is about double the amount of funding that was made available 10 years ago. And to see this growth in federal funding made available in Colorado's success at actually driving more funding into the state, I think is quite substantial and remarkable. So I'm going to spend just a short bit of time, as many of you probably know more about this than I do. But Colorado, over the last 2 years, has embarked on a review of its behavioral healthcare system. One of the things that was triggered by Governor Polis was the establishment of an interim committee on behavioral transformation. This past summer, they actually had a large meeting where these are 4 slides that were presented at that meeting that really kind of help earmark and pull out where Colorado not only ranks in its meeting of behavioral healthcare needs, but also some data to begin to tell the story of Colorado's behavioral healthcare system. It also describes some of the themes that many of the task force members were really kind of beginning to qualitatively kind of examine and articulate when it comes to the challenges in Colorado around access to care, concern with regard to timeliness of care, the adequacy of the workforce, payment challenges, and the various types of challenges when it comes to outpatient and inpatient and crisis care. Really, I think kind of speaks volumes with regard to this task force examination. They also began to kind of longitudinally kind of break out what the system of care looks like and where there are gaps in both mental health as well as substance abuse. And they begin to kind of, I think, are writing a narrative with regard to where some of those challenges are, which will be able to, I think, position the state very effectively to begin appropriately right-sizing the continuum of care as they intend to do with their behavioral health authority, which I'll talk about here in a moment. This interim task force also identified the fact that there's roughly a $1.5 billion in public funding that's supporting behavioral health. But these dollars are spread across 9 different agencies and about 100 different programs just in Colorado. Now, what was interesting, and I believe it was 14 years ago, around 2008, 2009, Colorado embarked on a similar examination of the behavioral health care system in Colorado when I was with the state. And we identified 11 agencies. I don't remember how many different programs, but 11 agencies at the state level were actually investing in and or delivering mental health and substance use care. Clearly, we've made some progress to go from 11 agencies to 9, but here is still an opportunity to really provide some greater synergy and standardization with regard to how Colorado's system of care really needs to work and work effectively for, most importantly, the people, the families, and the communities. And then finally, now this was published in September of 2020 in preparation for the task force that was noted earlier. But Governor Polis identified kind of 3 areas that he really wanted to focus on. One is the creation of a behavioral health administration, which I believe launches in July, but Dr. Morgan Medlock is the new cabinet appointee for Governor Polis to be the Behavioral Health Administration Director and cabinet level authority for the state of Colorado. And she is leading a number of the efforts that are currently in place and in progress for development, one of which is expanding and implementing a comprehensive care coordination system to really make sure that individuals and families are being able to have equitable access and then care coordination throughout the entire system based on their behavioral health needs. And then the third piece is really kind of the governor's 6 pillars, really kind of focusing for Colorado system that's focused on affordability and workforce and accountability, really the local and consumer guidance role, which I think speaks to the care coordination piece, really understanding that whole person and tailoring treatment and services to the individual, and then clearly having equitable, unbiased, unconditional access to behavioral health care. So I think at that point, let me go ahead and stop. This is my contact information. You can see our small yet mighty office on the right-hand side, and you're welcome to contact us anytime while we are based here. We're definitely resources for you beyond just today's presentation. So let me stop there, if that's okay, Derek. I think we got about 15 minutes to kind of open up for any type of questions.
Yeah, thank you very much, Dr. Smith. Yeah, I'd like to welcome questions from the audience now, and we're happy to have you jump on the audio or the video and ask your questions, or you can type them in the chat box.
Maybe I was talking too fast, and sometimes I can kind of get going. And so my apologies, Derek, and for the rest of you. But feel free to throw any questions in the chat.
I see a question from Megan, which is actually about what I talked about in the lead into this presentation. She asked if I could share a little more about the behavioral health care collaboration model that will be coming in the spring. What is that? So our second webinar in this series will actually be where we unveil that and go through the structure of it. As part of the Whole Health Innovation Project this year, in addition to onboarding organizations and helping them with tobacco treatment services, we also wanted to try to build this model that would be useful for agencies to think about the different options for people with tobacco dependence needs, treatment needs. So the model will be framed around tobacco cessation initiatives within the Colorado behavioral health system. And then, as I mentioned, next year we'll be building a toolkit to try to help agencies understand how to best apply that model and be able to recognize where to send people for treatment. So that's what I will say at this time. Other questions? You're welcome.
I see a question in the chat. So can you speak more to how well or not well you see efforts around integrating substitution prevention and treatment with general mental health care? To me, this makes so much sense, yet still notice a divide in the professional community. Same for primary care, medical care, and general mental health care. You know, Aaron, and actually, Aaron, it's nice to get your question. This is, I think, a real challenge. While theoretically, it does make a lot of sense, and we have lots of examples where it has been highly effective. There are still divides. One of the divide is money, quite honestly. And how do we assure that money is adequately supporting the primary care side of services, as well as the mental health and/or substance use care side of care? I think that training is still an issue. And then some of the systems, when we think about data sharing, when we think about the care coordination for individuals, knowing that historically our systems have been so separated and or siloed, the ability of making sure that individuals are able to kind of fluidly move within that system and know what that system is, we are still at an earlier pace. So I do think it's funding, I think it's system design, and clearly education and data coordination are probably the four things that tend to kind of muck up the system. One area that we've seen it work very, very effectively, and it's not the only area. Actually, I'm quite confident at the University of Colorado, there's been some great examples of where it's worked very well. And that's at the Coalition for Colorado Coalition for the Homeless, where they have developed a intentional integrated healthcare system where physical health, behavioral health is fully integrated, and they're warm handoffs, as well as they operate in treatment teams, and it's truly team-based care. So I do think that we're moving in the right direction, but we still have a fair amount of work to do.
Okay, and Dr. Smith, we have a question from Terry Walker.
Sure.
And that is, what kind of research is being done and what kind of programs being developed to support prevention and treatment of attachment disorders from early childhood abuse and neglect? Attachment disorders seem to be an important source of later substance abuse and other behavioral and mental health problems.
A great question and a great topic, and in many ways very timely. I do know that there's a fair amount of research that actually is being funded by the National Institute of Mental Health. But I don't have any great details with regard to where that is sitting and clearly how that is being incorporated into some of SAMHSA's work. So I probably will have to get back to you on some of the work and or point you in the direction of NIMH that has been leading some of that effort. The other place to actually, the other place now that I think about it, Derek, is one of the centers of excellence that SAMHSA does fund is the SMI Advisor, so Serious Mental Illness Advisor. It's located, it's based in the American Psychiatric Association, but they are a clearinghouse of information for various treatment and research models, and including both kids and adults. And I know that they've been tracking issues related to attachment disorder and post-traumatic stress. Dr. Amy Cohen runs that program, and I'm happy to kind of probably get into the chat, or you can actually go right to SAMHSA's website, www.samhsa.gov, and you can type in SMI Advisor and it'll take you right to their site. So that's probably the most effective way of doing it, but that would be a great resource as well.
And I'll call attention, Tracy is on top of it and has pasted that link in the chat box.
Thank you, Tracy. she knows that I cannot multitask very well. So.
Other questions? Okay, here's one from Yara. Can you talk more about the prevention efforts related to substance use, programs,
Absolutely.
funding, et cetera?
Yeah, absolutely. There's been a lot of emphasis around substance use since SAMHSA's inception. So I didn't speak directly, but this one of the first, the Substance Abuse Prevention and Treatment Block Grant that goes to every state, which in Colorado, I think is pushing $60 million. At minimum, 20% of that funding must go into community-based substance use prevention. And in Colorado, that has funded a number of different community, county, local coalitions that have focused on substance use education, early intervention, focused on kids and youth. In addition, Colorado has been a longtime recipient of what is known as the Strategic Prevention Framework, or SPF, where they have gotten additional federal dollars to actually build out specific youth and young adult programming with regard to substance use. That is focused on schools, that is focused on community organizations to increase education and awareness by youth and family members concerning substance use. SAMHSA, in addition, has expanded its prevention portfolio to do work with regard to harm reduction, particularly with individuals who are current users of drugs, such as injecting drugs like heroin, where we actually just this past December had a grant offering of $30 million for the first time ever for federal dollars to be used for syringe service programs. And so alongside SAMHSA's flexibility and block grant, we now have this discretionary grant, which we are hopeful that we will have some grantees within Colorado for that grant program to, again, use federal dollars for the first time on syringe services and other harm reduction strategies to help educate and support the health and for individuals who are currently using drugs. And then there are a variety of other programs that have been targeted with regard to alcohol use, marijuana use, methamphetamine use, and various prevention strategies such as the Drug-Free Communities Program, which used to be operated by SAMHSA, but is now being operated by the CDC, that supports local communities, again, engaging in community-based education and early identification across universal selected and indicated populations. Also, at the Office of Behavioral Health here in the state, there is a substance use prevention office that is stood up by Claudia Zundel. And then also she works collectively with the Colorado Department of Public Health and Environment, which houses a number of the opioid and cannabis prevention programs, as well as tobacco prevention programs for the state of Colorado. So there's a number of different federal investments, some of which coming from SAMHSA, but also investments from the CDC as well to support prevention efforts. That was a long-winded answer to a great question. I feel like we could have a separate presentation on that.
And I'll note that Tracy provided a link for Colorado Prevention 101 training for those who might be interested. And we have another question from Larry Green, which is, what is your thinking about models? What are they good for, and when, where are they a problem?
You know, Larry, I appreciate the question. And I think that at least at the federal level, the models provide models, particularly when we think about mental health and or substance use treatment and care. It provides us a mechanism by which we can better articulate the experience that individuals have or need to go through when they access, when they receive services, when they exit a particular clinical system. It gives us a structure upon which we can evaluate and how different systems kind of work or don't work. Models afford us the opportunity of actually standardizing metrics and experiences to make sure that funding is going into programs that have some core features. I think where it gets difficult is when models are dictating care, as opposed to taking away some of the nuances and the artistry of how we deliver care. There needs to be kind of, I think, substantial flexibility, and at least that flexibility afforded by government, because I think the last thing we want is where government is determining every aspect of care. And even when we think about how state laws and or federal laws may even define what a substance use disorder clinician or a psychologist or a psychiatrist or an OBGYN can and cannot do, that oftentimes kind of infringes upon some of our training and professionalism. And I think that's where some of the models have to be cautious. When we think about even models of workforce strategies, we want to think more about competencies rather than actual standards that can get in the way of the nuances and the flexibility when it comes to delivering services from a professional, individual, practitioner level, as well as to that system level. But I think it's a great question, and I think it's a very good one to kind of continually debate.
Okay, we've got a couple minutes left if anyone has a final question that they'd like to ask here. And again, we can accept people popping on audio or video too, if you prefer to do it that way. And good to see everyone's been making use of the chat box as well.
Well, I just want to put out there, I really appreciate all of you, your time in joining, and I do hope that you found this webinar valuable and helpful, and hopefully you're able to take away one or two nuggets that can help drive your continued passion and emphasis around healthcare. So thank you very much.
Yes, thank you very much, Dr. Smith, for today's presentation and for all your thoughtful responses to these questions. And yes, thank you everyone for attending today. And be on lookout for the announcements about our next two webinars in this series. So thank you all for coming today. And thank you, Dr. Smith.
You're very welcome. Thank you, Derek, and thank you for BHWP.